All right, well, welcome back to Ultrasound Grand Rounds this week. Pretty excited to be here. As always, we're getting into the spring. Last week, my family and I were out of town for spring break with the kids, and we were down south where it was warm and it felt great and it felt like spring was coming. And we came back here and it was a little bit colder here in Cleveland, but the sun is shining. It was 60 some odd degrees this morning. It feels good to be outside, but it also feels good to be in here and doing Ultrasound Grand Rounds today. And so today, I'm pretty excited. We're going to have another one of our residents join us for Grand Rounds today. We have Dr. Matt Youngman, who's sitting right here with me. He's one of our third-year residents who is in our ultrasound track, and he is going to be presenting a little bit about ultrasound. But before we get going, Matt, welcome to the channel, first off.
Thanks for having me.
First time you've been here. Tell me a little bit about the track and how you've been enjoying it and kind of some of the things that you're doing with the track.
Yeah, so I'm a PGY2 resident. This is my first year in the ultrasound track. I've been able to get a lot of experience just getting hands-on, doing a lot of cardiac echoes, all sorts of echoes in the emergency department, kind of bopping in and out, using ultrasound on shift, and then getting a little bit more focused and extra experience on my ultrasound rotation, where I kind of have free reign to go in the emergency department, kind of find interesting things to scan, and then kind of present it to the attendings and kind of go over and get some really good feedback about how to improve my ultrasound skills.
Cool. So a couple weeks ago, we had Dr. Lenke on. He was our other track resident that's been doing this with you. And it's been great. Like we had Dr. Lenke rotating specifically with us for some higher end elective stuff. Dr. Youngman's with us the last 2 weeks, right? This week and last, doing some more advanced ultrasound plus the scanning that he does just on his clinical shift. And this is part of it, just doing the being able to put together a presentation and learn how to teach and present that. So if there's anyone out there who is looking for medical education, looking for ultrasound education specifically in the form of residency, take a look at us, metrohealth.org/POCUS. And if you're looking for a fellowship, we offer that as well. Same website, metrohealth.org/POCUS. But with all that aside, I want to turn to today's topic and really get into what we're talking about, because I think you have some pretty cool cases that you have to share and some really interesting teaching points. So I'm going to get out of the way, turn things over to Dr. Youngman here, and he is going to bring to us his talk about ultrasound and how it impacts patient care.
All right. Thanks for having me, Tabit. So my focus of my talk is on things that definitely should not be there. This is kind of more cardiac echo focused. Like I said, my name's Matt. I'm one of the PGY2 residents. So I got a couple cases for you today. We're going to go through a few interesting things, and then we'll kind of talk about it. There's a little bit of literature review in there as well that we'll kind of go over some interesting things that I found. So with that, let's get started. I have no financial interest, so we can kind of skip this slide. So here's the objectives for today. We're going to just get some basic ultrasound knowledge. We'll kind of view the different cardinal views of ultrasound, and then we'll kind of go over some probe orientation things. We'll review and discuss a couple of these case presentations and how they can kind of best be applied to our role in diagnosis and management in the emergency department. And then lastly, we'll go over some literature. We'll try to draw some conclusions to the utility of ultrasound pertaining to some of these cases that we're going to go over today. Like I said, here's kind of the outline. I just kind of went over this. So we'll just jump right into the first case. So this case, it's a young female in her 20s. She's got a history of rectal adenocarcinoma. She's got some metastatic disease. She is on active chemotherapy. Important thing to note that she did recently have a chest port placed in the last few months. So she's coming in to the emergency department after some surveillance CT chest imaging showing that she has a right atrial thrombus. So kind of throwing out the diagnosis already right there, but we'll take a peek at it. Interestingly enough, she doesn't have any symptoms, no chest pain, no shortness of breath, no palpitations, no lightheadedness, no dizziness, and pretty remarkably, physical exam is completely normal. So let's take a peek at her CT. So this was prior to her arrival in the emergency department, and we'll go ahead and click through. As we're kind of scanning down, we'll start to see the aortic arch, and then pay attention to the right ventricular and right atrial area. We're going to start seeing a pretty large thrombus right there. So this is pretty large on first exam, and it's interesting that she doesn't have any of these symptoms from this. So recently, she also did have another chest CT approximately 2 months prior. And, I'm not here to talk about radiology and things like that, but they possibly noted in the scan more recently that there may have been a small right atrial thrombus on that scan 2 months ago. But they did note that, there's some sort of mixing artifact per radiology, and it's often hard to be able to definitively say if there was something there prior, which, the mixing artifact is just like this non-uniform contrast and some opacification of the blood vessels and the right atrius there that kind of skews the image. So this is my own still image that I took. I measured it myself. It's pretty spot on with what radiology read. It was about a 3.5 by a 3.3 centimeter right atrial thrombus there. So what does this mean, and where did it come from? So, is this myxoma? Is this some sort of metastatic disease that is kind of spread to the right atrium? It sure looks like a thrombus, so I think that's probably our leading diagnosis at this time, but we kind of have to get some more better and in-depth images to kind of be able to definitively tell kind of what this is. So here's some views. This was the echo that she had done actually prior to coming into the emergency department. So we're gonna take a peek at this first left image. This is showing the apical fourth chamber. And you can see that the heart's beating pretty nicely there, and she has a pretty large thrombus just sitting in her right atria. And then the image on the right is just going to be a still image that the ultrasound tech took. They measured it as about a 3.2 by a 3.5 centimeter thrombus. So let's go over a little bit of the hospital course and her ED visit. So she was started on heparin in the emergency department. She was admitted, as you can imagine. She was admitted to the solid tumor service. She got vascular medicine, CT surgery, cardiology consults. So pretty widespread and multifocal kind of evaluation by a lot of different surgeries. She ultimately underwent a thrombectomy by interventional radiology, and they noted that this thrombus that they found was actually attached to the inferior right atrial wall, but however, it was separate from her port catheter. So they got path on the samples that they were able to get from the thrombectomy, and it was negative for metastatic disease. So after a couple days, she was started on anticoagulation, and she was discharged, and she'll be following up kind of with vascular medicine. So this was the ultrasound that she had after her thrombectomy. So IR, I read the op report. IR said that the majority of the thrombus was able to be taken out, but there was some difficulty getting the entire thrombus out as it was kind of adhered to the right atrial wall. And, this is just a little bit of a summary of what happened. This is a nice picture of what they were actually able to get out of the right atrium. And so they thought the leading diagnosis from this was a thrombus, likely due to a port catheter versus some metastatic disease versus other etiologies like atrial myxomas or things like that. So I thought this was a really good case of some things that, we don't necessarily think about all the time. It's a little bit more of a nuanced diagnosis. I know for me, when I'm looking at, when I'm going in the emergency department, looking at cardiac echoes and things like that, I'm trying to focus on how good the squeeze is. Is there any pericardial effusions, what the chambers look like? But I just wanted to show this case to kind of illustrate some of the other more nuanced things that we may be able to find just on our basic bedside echo. And so with that, here on the left is a ultrasound image of a left atrial mass. This is actually a myxoma, but you can see how it's fairly large, taking up the majority of the atria there. And then in our next view, this is actually this is a subcostal view. They have biventricular thrombi that we can see kind of dancing around in the ventricles there. And then lastly, here's another view. This is a thrombus in the right atrium. You can see it kind of jumping around in there. So maybe a little bit more of a subtlety findings. You may have to kind of pay more attention on first glance. You may miss this, but this is another kind of fairly small thrombus that we can see kind of bouncing around in there. So before we kind of look at some more images, and I just want to make sure everybody's kind of on the same playing field here. This is just some ultrasound basics. This is our probe orientation. So for a parasternal long axis, we want our probe pointed to the patient's right shoulder. And then for a parasternal short axis, we want the probe to the left shoulder. And then for apical 4 and sub-xi views, that probe marker is going to be pointing to the patient's left. And then the IVC, we're going to be pointing to the floor. So I just want to make sure everybody's kind of on the same playing field when we talk about some of these images. And then here's briefly, these are our cardinal normal cardiac views, something that, I try to get great views of every time I'm in the emergency department. We got a parasternal long axis here. And by the way, these are all normal pathology. There's nothing going on in the heart here. So this is a nice parasternal long. We got a parasternal short here, showing a nice mitral valve. We can see all the walls moving pretty appropriately. The next view is the apical 4 chamber. This is a good view to kind of view all of the chambers all at one time. And we can see it's got good squeeze. We can see the valves jumping up and down. And then lastly, here's our subcostal view. So as I said, these are all normal pathology. These are kind of some of the views that we'll be running through during the next 20 minutes or so. So with that, let's jump into case 2. This is kind of our bulk of the presentation here. We'll spend some time talking about it. So this is a middle-aged male. He's got a history of IV drug use. He's coming into the emergency department for chest pain. He's been having it for a couple days, shortness of breath associated with it. Last IV drug use was approximately 5 days ago. And here are his vitals. He's a little bit hypertensive. He is tachycardic, normal respirators. He's saturating okay, but he is febrile at 101.9. So right off the bat, here's, when I see a patient like this, the first thing I want to do is, I'm going to throw a probe on their chest and see what I can find here. So here's our parasternal long view here. We can see the left atria, we can see the left ventricle, and we can see the aortic outflow tract. And, on first glance, I can already see there's something going on with that aortic valve. We got some leaflets, we got some kind of what I call, vegetations kind of sitting on that valve that we can see that are kind of jumping up and down with systole and diastole. So let's take a closer look at this valve. So the image quality could be better, but we can definitely get a lot of information from this. We can see that there's some sort of vegetations on this valve. So one thing that I've tried to do in my practice as I'm, getting more advanced with ultrasound is start looking at the valves more closely. Like before, like I said, a lot of the times I was just looking to get really good, clear views, looking for effusions, looking how good the squeeze is. But as I've progressed, I've been starting to look more at the valves, throwing some color on it, looking for regurgitation. So that's what we're going to take a peek at next. So as we can see in this view, you can see the aortic valve up top, and you can see quite a bit of regurgitation from that aortic valve, likely from these vegetations that we can see on there. And then you can even see a little bit of regurgitation on the mitral valve as well, going back into the left atria. So we didn't take a close look really at the mitral valve, but we can see here in this view that maybe they do have some sort of regurgitation there, possibly from vegetations if they have it on the aortic valve. And okay, so what are vegetations? I like to call them veggies. This is not the same case. This is a different image, but this is a picture of the mitral valve there that you can see that there's some something doesn't look quite right with it. So what are vegetations? They're kind of this echogenic material. They can be mobile. They can be attached to valves, although they can be attached to other places as well that can be considered vegetation. So there's a couple classifications of vegetations. They can be just vegetation, just kind of sitting on the valve. They can be destructive lesions, which are frequently associated with vegetations, and they may provoke things like valvular aneurysms. They can cause perforation, they can cause prolapse of the valves, and there can be downstream consequences of all of those things. Specifically, you can be in heart failure because of some of these things. And the third, main anatomical feature, which is often difficult to see on transthoracic echocardiograms, is the abscess formations, which are likely you'll see in aortic and prosthetic valves and endocarditis. So as I said, this is kind of a pretty clear case of aortic valve endocarditis in a IV drug user. So briefly, I just want to round out kind of endocarditis. So we got to talk about the workup and the treatment. So the labs, obviously the most important thing that we want to get here is blood cultures, and not just 2 blood cultures. We want to get 3 blood cultures, all from different locations at different times. And then we want to get basic labs. We'll get a CBC, BMP, ESR and CRP are reasonable. We want to get an EKG, obviously, and a chest X-ray. But for our standpoint, and the point of this lecture is, we want to throw a probe on his chest and see kind of what's going on with those valves. And then briefly, antibiotics, this could be an entire separate topic. There's so many different antibiotic regimens out there for bacterial endocarditis, and a lot of it is mostly wanting to be tailored to the bug that we think is there, and that's going to be coming from our blood cultures. But, vancomycin for MSRA is a pretty standard dose and therapy for endocarditis. And then briefly, the complications about this, we kind of went over it a little bit earlier, but, some patients, they can present in a spectrum of disease states. They can be asymptomatic, or they could be in florid cardiogenic shock. So oftentimes these people will have heart failure and cardiogenic shock, often due to the valve failure. They can get some pulmonary edema as well from the regurgitation of the mitral and aortic valve, or they can get severe rupture of the papillary muscles causing this regurgitation. So some of the standard of care there is to focus on afterload reduction. And then lastly, you can get florid respiratory failure, emboli. Oftentimes these people come in with heart failure or pneumonia, so you may need to think about intubating these patients if they're in florid cardiogenic shock. And then so now we're gonna kind of transition to kind of some background and some epidemiology of endocarditis. So interestingly, between 2000 and 2011, the incidence of infective endocarditis in the United States has been increasing. I've read some more recent studies that it's maybe up to 20 patients per 100,000. And so some of the risk factors and the patient factors that are coming in with this is age over 60, males, IV drug use, obviously, poor dentition, and then there's quite a bit of other comorbidities that can contribute to this: congenital heart disease, valvular disease. If you've ever had infective endocarditis before, you're kind of predisposed to having it again. And like we kind of saw in the first case, implantable devices, those can cause all sorts of different pathology. And then of course, HIV immunosuppression, you're more likely to be getting endocarditis. So this is a nice graph and picture of the incidence of infective endocarditis. In a recent study that was actually not a recent study, it was done in the 80s, but kind of concluded in the early 2000s. They noted that the average age of patients with endocarditis in the 80s was about 45. And now in the 2000s and, even now into, 2025, we're starting to see a trend of it's getting older and older that we're seeing this in patients. I think the average age now is almost into the 70s. And I think there's a couple reasons for that. Advancements in surgical care. Lots of people are living longer. They're having all these prosthetic valves that are being replaced, or valves that are being replaced with prosthetic valves. So I think people are living longer. We're starting to see the effects of endocarditis in the elderly population. So it has been becoming more. We're seeing this a lot more. So that's something to kind of keep on your differential when in a young person with IV drug use, that they're at high risk for this. But we're starting to see it in the older population as well. So with that, I do want to briefly talk about this special population of IV drug users, which I think, by far in my own practice is usually the cases of endocarditis that I am catching. So the tricuspid valve in this population is more commonly affected in IV drug users, and that kind of makes sense. You're injecting this medication, the drug use into your venous system. It's going to hit the right heart first, so you're going to get a lot of these patients with tricuspid endocarditis. So the frequency of involvement of the valves of IV drug users is kind of different than what we're seeing in the general population. So the tricuspid valve is often more involved. It's approximately 50% in IV drug users, and then the aortic valve is the next most common at about 18%, and then the mitral valve is about 10%. And then you can get some other mitral and aortic valve involvement at that time, and that's about 10% also. So if we compare this to the general population, i.e. not drug users or just anybody coming into the emergency department, likely they're going to get endocarditis of the mitral valve alone. And that's 20 to 40% of what we're seeing. And then the aortic valve alone is between 5 and 40%, which is quite a big spread. But definitely aortic and mitral valves are more commonly seen in the general population. So now that we got a little background about some of the epidemiology and the special populations, what kind of bugs are kind of causing this? So this is a nice graph kind of showing the percentage of bugs that we're seeing. This was done by a very large study across 25 countries with thousands of patients. And they noted Staph aureus is by far the most common bug when they get blood cultures. And then you got your coagulation negative staph, and then your viridans group, and then your bovis, and then kind of less likely going up, you get your fungus and your yeast, and then some of your other uncommon bugs. But the majority of these bugs are going to, you got to think of, gram-positive cocci, and you're going to be treating with vancomycin, and then as well as a gram-negative bugs, so your cefepims, your ceftriaxones. We got to start thinking about, how are we clinically making this diagnosis? I'm sure everybody's heard of the Duke criteria. The Duke criteria was initially published in 1994. They've had a couple modifications in 2000, and then it sounds like they had another one in 2023. And the purpose of the Duke criteria was to serve as a research tool and to help kind of standardize the definition for endocarditis. So if you have definite endocarditis, you got 2 of the major criteria, and we're going to go through that here briefly. You got 1 major, 3 minor, or 5 minor. So they classify all those things as definite. The next category is possible. You can have 1 major, 1 minor, or 3 minor. And then the last one is rejected infective endocarditis, which is just the lack of criteria met. Now, oftentimes that doesn't mean that they don't have endocarditis. We'll have to do more studies, tests, and things to kind of figure that out. So here's the Duke criteria in a nice little table. Here's the specifics of it as well. Major criteria, you need 2 separate positive blood cultures, and then you need an echocardiographic evidence of valvular vegetations, abscesses, or any sort of like regurgitation that we can see. And then the combination of the minor criteria, obviously, if you have a predisposition to it, you're immunocompromised, you have IV drug use. Temperature, great if you have it come in with a fever. By far, fevers are the most common presenting symptom of infective endocarditis. Almost 90 to 95% of patients have some sort of low-grade or high-grade fevers prior to their presentation. And then some other minor criteria, vascular things, emboli, infarcts, and we'll kind of go through in the next slide of some of the other things that we can see, like Osler nodes, Roth spots. And then, the next most common finding that you see with patients coming in with this is they're going to have some sort of murmur. Almost up to 85 to 90% of these patients will have some sort of new murmur that hasn't been documented that we're able to listen to and hear on bedside exam. So just for you to kind of keep that in your head and kind of classify these things, 2 major, 1 major plus 3 minor, or 5 minors, those are considered the definite diagnoses of endocarditis. So this was a nice picture kind of illustrating other physical exam findings that you can see with endocarditis. I know, this is kind of the textbook, what they teach us in medical school. They say that every patient that has endocarditis will come in with all of these physical exam findings. In clinical practice, I think it's less specific, and we often don't see any of these. I've maybe seen splinter hemorrhages on an endocarditis patient prior, maybe one time before, but I have not caught any Janeway lesions or Osler nodes or Roth spots. So, you kind of have to differentiate, the textbook answer and what we actually see in clinical practice. Now, this illustrates the importance of doing a good physical exam in addition to what we do best, our transthoracic echo, and kind of visualizing what's going on their anatomy. So here's some of the goals of echocardiographic evaluation. Some of the things that I kind of keep in mind when I'm at bedside and I'm running through a cardiac echo. You definitely want to determine the underlying anatomy. You want to see all the ventricles. You want to get good views. You want to see the presence of and size, location of where these vegetations are or where these abnormalities are. You want to keep in mind also that, let's throw some color on it. Let's see how well the valves are functioning, if there's any leaflet damage. And we want to take a peek at the size. If there's any downstream effects, like are they in heart failure because of this? Those are some of the things that we can take a peek at. And of course, we want to take a peek and make sure that we remember our 5 E's of echo. Obviously, we're looking for effusions, ejection fraction, the size of the RV and LV. We want to look at the inflow and the outflow. So this is something that, we want to keep in mind. Make sure we're doing a good echo, getting all of our views, and then kind of looking at some of the more nuanced things. All right, so TTE versus TEE. So there are pros and cons of each. The transthoracic echo, it's rapid, it's non-invasive. We can do it at the bedside. It takes 5 minutes. The sensitivity is pretty good. Estimated around 70% for native valves. It gets a little bit worse with prosthetic valves, but the specificity is pretty good also at 90%. Now compare that with transesophageal echo. It is more invasive. It costs more. It's a little bit more dangerous. People have to be sedated for this. The sensitivity is fantastic. The for native and prosthetic valves, the specificity is also very good, and the negative predictive value is also extremely good. So let's now take a peek at what kind of the flow sheet of when you're suspecting endocarditis. What are the steps? So this is kind of a busy slide, but I think the point of this slide is to just show that everybody gets a transthoracic echo. So this is something that, as emergency physicians, as residents, we need to be really good in our transthoracic echo skills. So everybody gets a TTE. So depending on what we see, if they have a prosthetic valve, likely they're going to need to get a TEE just because it's a little bit more diagnostic with a TEE. And it's important to talk about here that, when people get a TEE, this is they get 26 to 28 different views. They throw color on all of these images. It's very high quality, and we can see a lot of detail in this. Now, our bedside TE echo, we're getting a majority of 4 to 5 different views, but we can get a lot of information just from those 4 to 5 different views. So obviously, if you have a poor quality TE, you're likely going to get a TEE. At times, if you do have a positive TTE, they will, you see vegetations there, they're still going to probably want to get a esophageal echo also. So if your TTE is negative and you have low clinical suspicion, you can likely stop there. If you still have clinical suspicion, obviously we'll have to continue on working this patient up, and they'll get a TEE at that point. So the next slide, we're going to talk about just some limitations to transthoracic echo. Obviously, body habitus is a huge problem for us. It's difficult to get windows, difficult to get views. If you have COPD, you have big lungs, it's difficult to get clear images with that. If you have already at baseline aortic calcifications or any sort of calcifications on valves, that may skew kind of how well we can get some of these images. And then obviously prosthetic valves, it's a little bit more difficult to be able to get good pictures and see pathology that's going on around those valves. And then, this is kind of the point of this lecture here is user skill set. So this is something that, I want everybody to be on a level playing field, kind of know the basic views. And so, whoever is watching this, they can go to the bedside and have a good understanding of what views do I need and how can I make this diagnosis at the bedside. So now I kind of want to talk a little bit about an interesting study that I was reading about. It was published in the American Journal of Echocardiography in 2016. While the data is not the strongest that it suggests, I think it still provides a valuable point with the difficulty in making the diagnosis of endocarditis using ultrasound. We'll take a peek at their study design and some of the methods and kind of see what conclusions that we can draw from and we can apply to our own practice. So the goal of this study was how can we improve the negative predictive value for transthoracic echo in the emergency department. And if you remember, the negative predictive value is how likely you're basically not to have the disease. So just keep that in mind when we're going through this. So this was their kind of study design. They started off with transthoracic echoes in 2007 to 2014. They followed all of these transthoracic echoes up with a TEE 7 days after, and then they excluded some patients that make this diagnosis just very difficult, including if they have cardiac transplant, they have an LVAD, if they have prosthetic valves, and if they have complex congenital heart disease. So they had about 700, almost 800 patients that kind of met criteria for this, and they kind of classified them in two different categories, and they made this what's called strict negative criteria. So the strict negative criteria was moderate or better ultrasound quality on a transthoracic echo if you have normal anatomy, if you have no valvular problems, and if you have the absence of implanted hardware. So they made this criteria to better help us weed out the patients that can be discharged after, if they come in thinking, oh, maybe this could be endocarditis. I have a low suspicion. So they wanted to catch the population where we have a low suspicion. Let's apply these criteria rules. And then if it's all negative, they likely don't have endocarditis and we can sleep better at night sending them home. So they kind of cut these people into two groups: the TEE meeting strict negative criteria, which is about 104 patients, and then the TTE that did not meet strict negative criteria, which was about 680 patients. So a way that I kind of thought about this was it's kind of similar to the dimer. If you have patients that come in, a female, a little bit of shortness of breath, the diagnosis of PE kind of crosses your mind. You do have low suspicion, but you get a dimer. The dimer's not elevated, and then you can fairly confidently send this patient home and sleep well at night, knowing that you've ruled out pulmonary embolism in this patient. And that's kind of what the strict negative criteria was. It was a way to classify some of these patients where you have low suspicion that they're going to have endocarditis, and you get this TTE, they don't have anything, and then it helps you kind of justify sending them home. So I know this is kind of a busy slide, but we'll kind of walk through it. So like I said, all the TTEs are followed by TEE, so we're going to just focus on this standard approach up at the top graph. So the TTE with evidence of vegetation, there's about 129 people there. They followed that up with a TEE, and they classified them as did the TEE show that they had vegetation versus did the TEE not show that they had vegetations. And then on the right side of the graph, they showed that the TEE without evidence of vegetation, followed by a TEE, and they showed the different where they fell after they got the TEE. So I know, you're like, Matt, what does this mean? So I crunched some numbers for you so we can figure out what's going on here. And just for your own information, just to recall that this was the strict negative criteria. So I did a 2x2 table for everybody so we can easily kind of talk about the sensitivity, specificity, and the NPV. So this is for the standard approach. Their sensitivity was fairly poor, 36%. Their specificity was fairly good at 90%, and their negative predictive value was 86%. So these are the people not using the strict negative criteria. So now let's jump down to the bottom, the strict negative approach. So when they applied these criteria, and we found that the sensitivity, or they found that the sensitivity does increase when applying to the strict negative criteria, although the specificity was decreased. But they did improve their negative predictive value here. So that was kind of what the aim was. So this negative predictive value is how likely you're not to have the disease. So they did improve it. And so the study conclusions were that in patients undergoing evaluation for IE, transthoracic echo greatly improved the sensitivity and NPV for vegetations when using the strict criteria for a negative study. So they hypothesized that in low to intermediate risk patients with a strict negative transthoracic echo, follow-up TEE may not be necessary to exclude some of these vegetations that they saw. So, the data isn't the greatest, but it shows that, our bedside transthoracic echo plays a huge role in finding and diagnosing these patients. And then if you apply some of this strict negative criteria, you can sleep well knowing that the patient went home likely not having endocarditis. So I think it was an interesting study. I liked how they set up the methods. And so let's just quickly talk about some key points and takeaways here. So bacterial endocarditis, it often can present on a spectrum from asymptomatic to florid cardiogenic shock. So keep in mind, what you're looking for in patients when they come in complaining of chest pain, shortness of breath. Have a history of IV drug use. So keep that on your differential. Throwing a probe on their chest is going to be, help you gather the most information that you can get from that. And then, bedside echo, it is a tool for ruling in and out endocarditis. And, we've seen, that's just one study, but there's dozens of studies out there that shows that transthoracic echocardiography has been shown to help in the diagnosis of endocarditis, and it's backed up by some solid evidence. So with that, I want to say just have fun scanning. Remember your views. Keep your differentials in mind for some of the weird, more nuanced things that we don't necessarily see a lot of times on like these atrial myxomas and things like that. So I thought this was a really good closing point. This is Dr. William Osler, as we know from the Osler nodes. He said, few diseases present greater difficulties in the way of diagnosis than malignant endocarditis, and the difficulties of this, which in many cases are insurmountable. So I think that this is definitely still a true statement, and he said this back in 1885. It's still significant, and it remains a challenge for emergency physicians even nowadays. Here are my sources, and with that, thank you for having me.
All right. Well, we'll wrap things up here today. I appreciate you guys joining us, for the live version, but also for the YouTube version if you're watching this on either one of those. And Matt, I thank you again for being part of this today. It's great to have you here, just kind of get another person's spin on how to use ultrasound. You guys get to hear a lot from me, which is fine, but I always love hearing from other people and just kind of getting those little new pearls that I just hadn't thought about or just kind of are being refreshed. So thanks again. Look forward to seeing you guys next time. So in our typical cadence here, we are going to have our next lecture in about 2 weeks, and Dr. Werner will be back to do part 2 of her ocular ultrasound lecture as we're kind of hitting the basics here this year. We're kind of refresh that ocular because we haven't done it for a few years. So we're going to refresh that for you guys. Look forward to seeing that. This lecture and last week's ocular lecture will be posted on YouTube shortly for you guys to review and consume. If you're watching it now, you have it available to you. But if you want to catch anything else that we've done, see any of the other lectures that we've talked about, refresh on some other topics, go ahead and go back to the YouTube channel, MetroHealth Emergency Ultrasound. While you're there, if you like the material, hit that subscribe button so that you can easily get back to it. Hit the like bell or the notification bell, so you can be notified every time we push something up, or the up thumbs up arrow if you like it. It just helps out our metrics and help kind of get our message out to folks as they're looking for ultrasound needs. I've received a lot of interesting and unique comments on the channel about how we've reached a whole bunch of different learners. And so that's always fun just to see. So with that being said, we're going to wrap things up here. We will see you guys next time. Thanks for watching. Have a good week. Happy scanning. See ya. Bye.